This lecture is on high-risk newborn assessment and nursing care. Skeletal and nervous system injuries most often occur by way of birth trauma. For example, fractures, in particular clavicle fractures, happen during breech birth or shoulder dystocia in newborns with macrosomia. And remember, macrosomia are those newborns that weigh greater than 4,000 grams. The mid-clavicle fractures are the most common type of fractures, and they're secondary to shoulder dystocia. What you would find upon an assessment in these newborns is that newborn is not able to move the affected arm. So its Moro or startle reflex would be asymmetrical. And we usually treat these fractures by limiting the movement or motion of the arm. So we would kind of pin the sleeve of the affected arm to the opposite side, creating somewhat of a sling. And these fractures heal fairly quickly. Facial nerve palsy is attributed most often to pressure from forceps delivery. Upon an assessment, you'd again find an asymmetry in appearance, especially when the newborn cries. The affected side would appear smooth, where the unaffected side would have more wrinkles when the baby cries or opens its mouth. The affected or the paralyzed side, the eye will remain open as it can't blink. Usually recovery starts to happen within the first week, but full resolution of the paralysis may take up to a couple of months. And so it's important as nurses, when we're doing teaching, that we offer reassurance to the parents that this is temporary. What we want to be concerned with and provide nursing care for is the affected eye. And so we would cover that with some kind of patch, and then they even provide temporary tears as this newborn can't blink on the affected side. Teaching related to feeding, whether it's formula feeding in a bottle or breastfeeding, will have to be collaboration with a lactation specialist and a neonatologist. Brachial paralysis, again, which is temporary, is associated with macrosomic babies who were delivered with shoulder dystocia, or babies who were delivered by breech who had shoulder dystocia as well. And it results from the stretching and hemorrhage within the brachial nerve and the tearing of the root of that brachial nerve. Upon assessment, we'll see with these babies, the affected arm would be adducted, meaning close to the body, usually internally rotated. The shoulder of the affected side does not move. So you would see a asymmetry in the Moro or startle reflex. They would have a weak grasp on that affected side. And treatment involves, for the first week, immobilizing, putting the baby in that sling-like position. and then after that start to introduce gentle passive range of motion, because we don't want to we want to try to prevent contractions. The next 3 slides bring attention to infants born to a diabetic mother, which we've talked about in previous lectures. Problems associated with macrosomia and hypoglycemia, signs and symptoms of a hypoglycemic infant are presented in those next couple of slides.
So if you recall that insulin does not cross the placenta. So as the diabetic mother is receiving insulin, or as she's producing her own insulin, it does not cross the placenta. However, the glucose does. And so the fetus is then forced to produce its own insulin. And so then there's an increase in insulin production because of this hyperglycemic state that the mother is in, and that's being passed on to the fetus. So the fetus is developing extra insulin to keep up with this hyperglycemic blood. And insulin is a primary growth hormone for intrauterine development. And so this is why these babies are at risk for being big, because of the extra insulin that they produce, and that insulin having this growth hormone effect on the developing fetus. Hypoglycemia occurs in a newborn, or a newborn who was born to a diabetic mother, whether it was gestational diabetes or type 1 or 2 type diabetes, is at high risk for hypoglycemia because of that extra insulin production that the newborn was making in utero to keep up with the glucose in the blood being transferred from mom to fetus. But once the cord is clamped, that blood supply is stopped, and now the newborn's circulatory system is working, and it is not in a hyperglycemic state. So we have all of this extra insulin because the fetus was producing it, and now we have this temporary hypoglycemic state because of that overproduction of insulin.
Next, we're going to move into neonatal infections. Specifically, we're going to talk about torch infections and some bacterial infections. So just as a review, congenital infections are those infections that are passed genetically from mother to the fetus prior to birth. And then acquired infections are those that a newborn would get after birth, coming in direct contact with an infected individual. Or nosocomial are those infections that are acquired within the hospital. The next couple of slides, we are going to look at a group of infections that have the acronym of TORCH. So we're going to talk about toxoplasmosis, other, rubella, cytomegalovirus, and herpes. Toxoplasmosis is a parasitic infection caused by a protozoan. It's most commonly transferred by hand to mouth after touching cat feces when you're changing the litter box, or through gardening in contaminated soil. So if you have a cat who's an outdoor cat that may defecate in the gardening, in the soil, and you go out and you touch that and come back in without good hand washing, you could obtain toxoplasmosis. Also consuming undercooked meat such as pork, lamb, and venison can also be a route of transmission. So for the most part, women are asymptomatic. And so they can have the virus and not know that they are at high risk of transmission to the fetus. So some of the problems if a fetus contracts congenital toxoplasmosis is low birth rate, an enlarged liver, jaundice, intrauterine growth restriction, and neurological damage, just to name a few. And so prevention is the key, and that's why a good history during preconception counseling or at the initial prenatal visit, asking if a woman has a cat and who changes the litter box is crucial. We would encourage women who do have cats to have someone else change the litter box, or if they must change the litter box, use gloves and thorough hand washing afterwards.
Toxoplasmosis is caused by a parasite that's found usually in cat feces or acquired by eating raw or undercooked beef or pork. So moms who have cats, particularly indoor, outdoor cats, cats who are allowed to, go outside in the yard, and walk and roam freely and then come back in the house. If the mom is handling the cat litter or again consuming undercooked beef or pork, she is at risk for acquiring this parasite and causing toxoplasmosis. So here I've listed common symptoms, but note that most often these women are asymptomatic. If she does have toxoplasmosis, it puts the fetus at increased risk for abortion, stillbirths, and congenital anomalies. And so the best way to treat is to prevent. And so again, when we do our initial prenatal visit, or even better in the preconception counseling, we ask questions about, do you have a cat? If so, does that cat go in and outside? Who handles the litter? And if a woman does have a cat, we don't tell her, okay, now you got to get rid of your cat for 9 months. We just have her, if she has a partner or support persons, have them change the litter box, keep the litter box in a closet. If she's alone and she has the cat, have her use, making sure she's using gloves, and trying to keep the cat from being outside to decrease its risk of acquiring that parasite. And so there is no medication to treat toxoplasmosis. You kind of let it run its course and just provide supportive care.
The O in the torch is other infections, and we've talked about gonorrhea, syphilis, and chickenpox in previous lectures, and this chart here just gives you a overview of how the newborn is affected, and treatments for these infections. Rubella, which is more commonly known as German measles, is spread by droplets through direct contact with a contaminated object. And so a pregnant woman who has rubella can transmit this through the placenta. Okay? Education and prevention, again, is the key to preventing this transmission. And again, with preconception counseling, women would get screened for measles, mumps, rubella through a titer or screening called MMR. If a woman is not immune, if she's non-immune to rubella, then she would receive the rubella vaccine prior to pregnancy because it's a live virus, and would be encouraged to not conceive for at least 3 months. If a woman comes for her prenatal visit and she's rubella non-immune after that lab test, then she would get the vaccination in the postpartum period prior to discharge from the hospital. Cytomegalovirus, or CMV, is the most common or leading cause of congenital infections. The fetus is at the greatest risk if the mom develops CMV in the first trimester or the early second trimester. And CMV is the leading cause of hearing loss and intellectual disability for newborns in the States here. So a pregnant woman can acquire CMV primarily from sexual contact, blood transfusions, kissing. It's part of the herpes simplex group virus. All right, so it can be found in just about all body fluids. And some of the side effects or things that the newborn or fetus are at increased risk for is abortions or stillbirths, low birth weight, intrauterine growth restrictions, like I said, leading cause of deafness and intellectual problems or mental retardation. We're talking about bacterial infections. Specifically, we're going to talk about group beta strep bacterial infection. So we'll look at that in the next couple of slides here. So group beta strep, or GBS, can be found in the vagina, can be found in the gut of healthy individuals, and we can be carriers. You have no symptoms, and we don't test for GBS only in pregnancy. So this carrier state can be transit, meaning that it can be temporary. So in one pregnancy you can be positive for group beta strep, and in another pregnancy you can be negative. Alright, so the overgrowth of this bacteria is what can lead to an infection in the newborn. And so we screen mothers at 35, 36 weeks for group beta strep with a swab. So we take a Q-tip, insert it into the vagina, and bring it down to the anus and send that out for a culture. And if a mom is positive for group beta strep, she would get treated in labor. The drug of choice would be penicillin, and she'd get a dose, and we would continue to give penicillin every 4 hours until she delivers, to reduce the chances of transmission. So it should be noted that group beta strep is not a sexually transmitted infection, and it can happen in one pregnancy and not the other. So this diagram shows the route of transmission. So you have a mom who is positive GBS. So she has a 50-50 chance of baby being positive with group beta strep. And even those babies who are positive, 98% of them won't have any symptoms. But you have to be on the lookout and doing thorough assessments and doing cultures on these babies for early onset sepsis or pneumonia or meningitis. And then you want to talk to the mother and teach about signs and symptoms for late onset as well. And so these babies will have early follow-up appointments with the pediatrician to make sure that there is no late onset. So I just want to bring your attention to some of the risk factors for newborns who could be infected with group beta strep. If you think about moms who go into labor or rupture before 36 weeks, these babies are at increased risk for group beta strep because we've not done the culture on them yet. So if a mom ruptures or goes into active labor before 36 weeks, she's going to be treated prophylactically in labor with penicillin. So again, moms who've had previous pregnancies with GBS are at increased risk, not a certainty, not a positive that this pregnancy will be affected by GBS, but they are at risk. If early on in the pregnancy a mom has a UTI and the culture comes back and it shows that there's group beta strep in the urine, then this mother, depending on the practices of the provider, may get treated in labor as well. Even if her 36-week culture comes back negative, she may still get treated because there was a history of GBS in this pregnancy. Because group beta strep can have early or late onset, it's imperative that we as the discharging nurse knows the mother's GBS status. If she was positive, that she was treated, and that there's been proper screening and assessment of this newborn prior to the newborn being discharged home. If the mother's GBS status is unknown, let's say she came in no prenatal care and came in precipitous, and there was no time for antibiotic treatment in labor, then this newborn should have had a GBS workup before being discharged home. So it is imperative that we know the antenatal and intrapartum history, because that affects newborn care and especially discharge home, early discharge home. Newborns can get fungal infections. The most common is oral thrush, when they have yeast in the mouth. And you see, as you can see on this picture there, they'd have these white patches, and you would treat the newborn with antifungal medications. And if a mom is breastfeeding, that she can use that medication on the nipple and areola area to prevent even further transmission. Perinatal drug abuse is the use of alcohol or any other drug by a pregnant woman. The incidence of substance abuse in pregnancy varies, and it varies because most pregnant women are a bit reluctant to reveal or disclose the extent to which they are using a substance that is known to be a tetralogy, something harmful to their fetus. The placenta acts as we know as a transport of nutrients from the mother to the growing fetus. That's the same for substances or illegal substances or alcohol or nicotine. The placenta doesn't act as a barrier. So, for example, a mother who drinks alcohol, her fetus will have the same blood alcohol level that she has. So there is no filter. So these babies, along with their mother, experience the substance abuse, the use, and eventually the addiction. And that's when we'll see those babies who have withdrawal symptoms because they're no longer receiving that high quantity of drug that's like their mother would. Nicotine can cause vasoconstriction, which leads to reduced utero-placenta blood flow, so blood flow to the placenta, causing decreased birth weight, can lead to abortion, prematurity, placenta abruption, and fetal demise. Marijuana use can cause inadequate weight gain. The newborn may be born with tremors, prematurity, and can also have an effect on intrauterine growth restriction. So with fetal alcohol syndrome, it's not known how much alcohol it takes for a fetus to be affected by alcohol consumption. So that's what I mean by dose unknown. It could be potentiated by other substances. So mothers who have an alcohol addiction may also smoke or may use other drugs, illegal drugs, or prescriptive drugs that may have effects on the growing fetus as well. So fetal alcohol syndrome can present a whole wide range of birth defects, specifically structural anomalies in the face, growth delays, and then there are neurological disabilities, developmental delays, behavioral problems, those types of deals that newborns born to mothers who had an alcohol issue can be born with. This picture here just gives you a visual of some of the facial characteristics of a newborn born with fetal alcohol syndrome or AFS. These babies usually have short chins, short noses, their ears may be low-lying. The folds in their eye, where the eyelids may be a little bit deeper. The philtrum, which is the little dent above your lip, between your lip and your nose, is usually flat. It may be absent. So if there's not a deep philtrum, that's usually a positive sign of fetal alcohol syndrome.
Again, it's extremely important to know some of the characteristics of a newborn with fetal alcohol syndrome. So again, here is a picture pointing out some of these facial characteristics that you should be familiar with.
Now we're going to move into some more congenital anomalies of the newborn, specifically talking about cardiovascular congenital anomalies, central nervous system anomalies, and gastrointestinal anomalies. So congenital heart disease is a structural deficit or defect involving the heart or the great vessels or both that again are present at birth. Okay, so these happen in utero. So it could be genetic or it could be effect of some teratogenic that the mother could be exposed to while during the pregnancy and during the development of the embryo when the heart is being developed. So these defects can range from very mild and the newborn appears healthy at birth, or they can be severe where you would notice that this newborn's life is in jeopardy immediately after birth. So Tetralogy of Fallot, there's actually 4 different defects, and they're listed here on the right. And the major problem is that there's going to be decreased pulmonary blood flow, okay, because there's an obstruction of the ventricle septal defect between the right and left sides of the heart, and this is allowing desaturated blood, so blood that has less oxygen, to shunt right to left, and then the desaturated blood enters excuse me, the systemic system. So there isn't going to be good oxygenated blood flowing through the body. And so you would assume, or that you would see, that these babies are have issues such as dyspnea. They're going to have the increased workload because the heart is working more to produce oxygenated blood, and so these babies they're definitely going to have some color issues because the body isn't being perfused. So with transposition of the great vessels, is just what the name implies, is that those great vessels, the pulmonary artery and the aorta, are inserted in the opposite ways. So you have, again, this desaturated blood being pumped through into and throughout the systemic system, causing pulmonary congestion and decreased cardiac output. So these babies will have congestive heart failure. They'd have a dusky or gray appearance. So these would be those babies that have that central cyanosis, which is an extreme problem. Okay, so the surgery for these babies would need to be happening right away. Next, we'll talk about central nervous system anomalies, in particular neural tube defects, NTD. Neural tube defects describe congenital central nervous system structural defects and they can be defects that involve the spine, which would be spina bifida, or involving the brain, and that was where you would get these cephalies, anencephaly, hydrocephaly, or microcephaly. So with neural tube defects, what happens is the neural tube in that early development, the neural tube develops into the brain and the spinal cord. And somewhere along that development, that tube fails to close properly during that embryonic phase. Alright, and so it usually closes anywhere between 17 and 30 days of gestation. So it happens fairly early, and this is why it's important for moms to have folic acid, enough folic acid on board, because of that early period of closure in the first trimester. Okay. And we talked about this when we talked about antenatal screening, that women who have high levels of AFP are at increased risk for neural tube defects, and that we know that the numbers of neural tube defects have decreased with the push for folic acid early on in the pregnancy, and even more importantly in that preconception period. So there's two types of spina bifida, and spina bifida usually happens in the lower level of the spine area. So you have meningeal, and these are a form of spina bifida that's less severe, and there's an opening in the spine through one of the bony, through a bony defect, and there's this, the meninges are herniated through the meninges, and the spinal fluid are herniated through this bony defect. Okay, so it does not involve the spinal cord or any nerve roots, and so surgery is the treatment for meningeal seals. So then a more severe type of spina bifida is myelomeningeal seal. And so this is where there is actual protrusion of the spinal cord and nerve roots through that bone defect, that opening. And so the higher up this myelomeningeal seal, the greater the effect. So paralysis, things like that, or some deficit in the ability to walk with these. Okay, omphalocele and gastroschisis are congenital anomalies of the abdominal wall, either at the umbilicus or just to the side of it. And this is where some of the gestational the gastrointestinal contents, such as the intestines, protrude outside of the abdominal wall. There is some type of defect there. There may be a hole, or this the intestines are protruding through the umbilicus, the umbilical. Okay, so with the omphalocele, the abdominal contents are in a sac, and they are protruding through the umbilicus. All right, so the exposed or the protruding organ is covered, whereas the gastroschisis there is a defect in the abdomen wall to the side of the umbilicus, and that intestine is exposed. There is no covering, there is no sac. And so in utero, this exposed intestine is exposed to the amniotic fluid, and so there's no protection of that herniated organ, that organ that's protruding out. And so it makes the protruding organ, thick, edematous, and it's inflamed when these newborns are born. And depending on the size of the omphalocele or the gastroschisis, and again the skill level of the provider, I have seen women have their babies delivered vaginally. If they are large anomalies, then a C-section would be warranted to prevent further damage to these organs. Babies that are born with gastroschisis, that exposed intestine needs to be covered with saran wrap immediately after delivery to decrease infection and to keep the area moist. So it may be covered with some type of cloth with saline to keep that organ moist. So know that omphalocele, the herniated organ, is covered in a sac and usually protruding through the umbilicus, whereas the gastroschisis, the herniated organ, is not covered by a sac and is usually to the right or left of the umbilicus.
Here I've provided two videos that give more detail about the various differences between omphalocele and gastroschisis to further help with understanding the difference between the two.
And then finally, just wanted to talk briefly about autosomal chromosomal anomalies, specifically Down syndrome, which we also call trisomy 21, where we know that there is an extra chromosome noted, and know that the incidence or the risk of Down syndrome increases with age. So the later a woman gets pregnant, the higher her chances are of having a baby with Down syndrome. And so here I just list a couple of distinct characteristics that would lend itself to newborns who have Down syndrome. And so the biggest thing for nurses with parents who have babies with autosomal chromosomal anomalies is teaching and providing appropriate resources for support and management of a baby with special needs.
As with fetal alcohol syndrome, it's important that you know some of the distinct characteristics of a baby with Down syndrome. And so I provided some pictures that coincide with the descriptions that were given in a couple of slides above here. And, keeping in mind, noting one of the distinct characteristics is that simian palmar crease, that the crease in the palm of our hand that usually stops either midway or 3/4 of the way around across our hand with a newborn with Down syndromes or an individual with Down syndrome. That simian crease goes all the way across the hand. And then one of the other distinct characteristics is the eyes. So knowing those characteristics are important.